Good morning, everyone. My topic is feeding gastrostomy. Myself, Dr. Anubhav, PDF Fellow in Neonatology at Graphic Era Institute. My moderator is Dr. Syed Muiz Ahmed, Associate Professor, Pediatrics at Graphic Era Institute. First of all, we'll see the indications for gastrostomy feeding. First is incapacity or limited ability to eat. That is seen in swallow dysfunctions, which is commonly seen in prematurity, neurological disorders also. Congenital abnormalities like craniofacial malformations, esophageal atresia, and tracheoesophageal fistula. Inability to meet requirements by oral intake. For example, fatigue and muscle weakness seen in cardiac and respiratory diseases. Increased metabolic needs seen in congenital heart diseases, BPD. Increased nutritional losses seen in impaired digestion, impaired absorption, or excess GI losses. Inborn errors of fasting adaptation seen in glycogen storage diseases or defects in gluconeogenesis. Now, what are the advantages of feeding gastrostomy? It is the most preferred route of tube feeding as it closely simulates the physiological, digestive, and hormonal responses. It retains the microbial properties of the stomach in the feeding process. The tube insertion is easier. It improves the weight and mid-arm circumference of the child. It reduces the feeding time, and it also improves the quality of life of caregivers and also the children. Available devices are gastrostomy tube, long balloon gastrostomy tube, percutaneous endoscopic gastrostomy, that is PEG, and gastrostomy button. First of all, gastrostomy tube. It is inserted endoscopically or surgically via open or laparoscopic technique through the abdominal wall and directly into the stomach. As you can see here, the gastrostomy tube is directly into the stomach through a stoma. Next is long balloon gastrostomy tube, also called G tube. It is a tube which has three ports. One is for feeding port, one is a drug port, and one is a balloon port. It is a long extension on the outside, and a balloon is seen on the inside, which retains the gastrostomy tube. Next is percutaneous endoscopic gastrostomy tube. It is a tube which is inserted with the assistance of a gastroscope. It is held in place with an internal bumper and an external fixator. It has two ports, feeding and drug port. Next is gastrostomy button. It is a skin level button gastrostomy tube which is inserted into a preformed stoma. It is cosmetically better as it is not a long port outside hanging there. Now the position and securement. First of all, we assess the stoma and monitor the position of the tube. Next is monitor for the movements of the external disc, which should sit flush with the abdomen. Next, we check for the migration of the tube by checking the markings on the tube daily. And we have to secure the tube to minimize the pulling. Daily care of established gastrostomy. Bathing and rotation. In this, we clean around stoma and under the external fixator once or twice daily with plain water or soap-free wash. And we have to pad dry to reduce the risk of granulation. Then we have to rotate the gastrostomy tube 360 degrees, both clockwise and anti-clockwise. The tube rotation should be done daily. Next is skin barriers. If there is any, next is dressings. If there is any oozing or the dressing is wet, we have to change the dressings. We can use the skin barriers. If there is any ooze, we can use white soft paraffin or zinc creams. Then we have to secure the tube. We have to monitor the fit of the gastrostomy tube when we are cleaning the tube daily. And we can, what we can do is we can keep the extension set disconnected when not using to secure the tube. Now, factors affecting choice of feed. We have to see the nutritional status of the child, the energy protein requirements of the child, inability to tolerate large volumes of the fluid, if there is excess weight gain, increased energy requirements of the child, if there is constipation, and if there is GER. We have to choose the feeds accordingly. Potential problems related to gastrostomy tube. They can be accidental removal of the initial PEG or G tube. Balloon tube can fall out. Leakage from or around gastrostomy tube. There can be irritation, skin redness, bleeding, soreness, or oozing. There can be blocked tubes. Granulation tissue can be there. Pumper can be buried, or they can be broken or missing low-profile extension tubes. Complication related to the child. There can be infections like pneumonia from aspiration or contamination of feeds, gastrointestinal complications like nausea, vomiting, diarrhea, abdominal distension. Metabolic complications like hypokalemia, hyperglycemia, acid-base balance disturbance like metabolic alkalosis, and there can be refeeding syndrome, which is hypophosphatemia, hypomagnesemia, hypokalemia, and vitamin B1 deficiency. Contraindications of gastrostomy feeding are abdominal wall infections at the placement site, if there is severe ascites or peritonitis, if there is severe coagulopathy, and the child is hemodynamic unstable, will not put gastrostomy tube. How to wean? First of all, we have to assess the oral motor function of the child. Then we have to assess the safety of swallow by contrast video fluoroscopy. There should be multidisciplinary approach, including dietitian. Dietitian will advise on food texture and consistency and assist in the development of behavioral feeding plan by allowing the hunger satiety cues to develop. The speech therapist and language therapist will provide oral stimulation and deal with eating related maladaptive behavior. And psychologists will also see the eating related maladaptive behavior like grimacing, mouth closure, gagging, and nurse and pediatrician are also required. And finally, we have to test the ability of the child to maintain their nutritional status with oral feeding alone for a few weeks before removing the gastrostomy tube. Thank you.